Morning, everyone. And I think this is what you call saving the worst for last. So it's my pleasure and honor to be here with you this morning to share our experiences with using multifocal intraocular lenses. I work in the Philippines at the Peregrine Eye and Laser Institute. And the only financial disclosures I have are these. We're fortunate to be practicing in a time where we have all this technology to help our patients get the vision that they want. So we're spoiled for choices actually. And in most cases, we're able to allow patients to achieve spectacle independence. These lenses also allow our practices to generate additional revenues. But the key to having a successful practice is to be able to match the patient with the lens or the lens with the patient. And we have to understand the capabilities of each lens as well as the needs of the patient to be able to get a good outcome. So this is the current summary of the current IOL landscape. And we all started out with monofocal lenses that just let you see one distance. But now we have multifocal lenses as well as extended depth of focus lenses. And as I said earlier, they can be, I describe it to patients as 3-in-1 or 2-in-1. It seems to be easier for them to understand that. And we also have the option of mixing and matching these different lenses. And because we practice in different parts of the world, the cultures are different, the lifestyles are different, so we have to understand our own patient population to be able to figure out what is best for each individual patient. And as we're fond of saying, there is no free lunch in optics. Basically, we're looking at two things. We can trade a greater range of a greater range of vision, but we actually lose some quality of vision, or we can have the best quality of vision, but we lose a little range of vision. So this is the discussion we should have with each and every patient. And given all the lenses we have, we eventually, not perfectly, but we find out what lens might be most suitable for each patient. And of course, if things don't go well, you have these add-on lenses to help us correct the problem. So for this morning, we'll be focusing on multifocal lenses. And the main advantages of these lenses is they have the greatest ability to reduce spectacle independence because they give you the greatest range of vision. And that this allows the patients to have enhanced lifestyle and convenience. They don't have to walk around or travel with carrying glasses. But the disadvantages are also several, particularly, as you saw Dr. Allison mention earlier, nighttime vision may be compromised. They may be reduced contrast sensitivity. The patients tell you there's a film in their field of vision. Multifocal lenses are also more surgically demanding. It's not just getting the lens in the eye and getting the right biometry, but the lens also has to be well-centered. They're also more costly, so these patients have higher expectations because they spent more on their surgeries. And even if you do everything correctly and everything is good, your refractive outcomes are good, a certain number of patients are unable to neuroadapt. So whatever you do, they don't feel that the vision is good. So it's also important for us to manage the expectations of these patients. We don't promise them supervision. So the screening process can be reduced to this. You have to identify which patients are suitable for multifocal lenses. Then you have to find out if there's anything in their eye that will disqualify them from getting these lenses. You have to do accurate biometry so that the lens you put will be suitable to that eye. And lastly, before you go into surgery, there must be some counseling of these patients. As we say, if you tell a patient something might happen before the surgery, it's an expectation. But if you tell the patient something happened after the surgery, it's a complication. So we try to manage the expectations of these patients and counsel them. So first, not all patients are suitable for multifocal lenses. If a patient says, I don't mind wearing reading glasses to read, I'm happy, I've been doing this for years, I don't mind wearing reading glasses, let's not try to convince these patients to have multifocal lenses, because if everything goes well, the patient might be happy. But if things don't go well, then you have an unhappy patient. We also want to make sure that they have a healthy ocular surface and healthy back of the eye. And we also want to make sure they have realistic expectations. If a patient insists that they see everything, even at midnight, they can count the number of ants walking on the wall, these are not good patients for multifocal lenses. And we should be cautious if the patient tells you they have a history of some ocular disease, if their refraction is changing from visit to visit, if they've had a history of refractive surgery, or they have unrealistic expectations. So this is the process for premium IOL selection, and I think the most important is to do a good psychiatric and lifestyle assessment of these patients. This is the most important. Unfortunately, they do not teach this in ophthalmology residency or even in medical school. Okay. So you have to learn it the hard way from your own practice, and then make sure there's no ocular comorbidities, and then do good biometry of both lower order aberrations and higher order aberrations. And then if the patient does have higher order aberrations, sometimes this can be fixable. Like if there's a dry eye, you can treat that. If there's pterygium, you may remove that to improve the ocular surface. And then you repeat it, and if the higher order aberrations improve, then these patients may be considered for multifocal lenses. So we use a variety of lenses in our practice, and I can tell you before the pandemic, we were mostly fine vision and PanOptics users. But during the pandemic, somehow the Philippine Medicontur MedRep was very persistent. She would be coming to the clinic on a weekly basis with her mask, and she would be covering us. So after the pandemic, there was an increase in number of cataract patients. So we were now overloaded with work. So we thought, let's try the Medicontur lenses, and we were very happy with the outcomes. So from being a minority, the Medicontur lenses now comprise the majority of our practice. So we have to match the lens to the patient, and it's very important that you do some evaluation of the patient's anterior segment to find out if they have diseases that might limit the patient's response to these multifocal lenses. So it's important to screen them, and normally we do topography. In cases of doubt, we'll do wavefront aberrometry. You should do specular microscopy. Patients with these endothelial dystrophies don't tend to have the best outcomes. And if everything is okay, then you may consider these multifocal lenses. But if it's not okay, then you have to, even if the patient wants, you have to explain why they're not good fits for that. Also very important is evaluating the back of the eye, especially in patients in our part of the world where their cataracts might be dense. You might not be able to see that they have a small macular hole or a small epiretinal membrane. And if you don't detect that and tell the patient that, and you put in a multifocal lens and they don't get a good outcome, then the patient will kind of blame you for either doing a bad surgery or not detecting it before the surgery and telling them they're not suitable. So this is very important in premium eye care. Okay, other important measurements will be optical biometry. If it's going to be a multifocal lens, then at least you must do optical biometry. And in our practice, sometimes we do it 2 times using two different machines just to make sure that our measurements are correct. And if there's not in agreement, we might even do a 3rd or 4th machine. I think corneal topography is important because this helps you screen out patients with corneal issues. And wavefront aberrometry or corneal topography can also help you determine the pupil size, the angle kappa, and higher order aberrations, which will help you in selecting the lenses. And now there are many multifunctional machines that does many of these things in one go, so it's more efficient if you have these multifunctional machines to do the measurements. Okay, so word about pupil size. So especially with the Liberty lens, this is a pupil dependent performance. So we want to select patients where the pupil size is between 2.5 to 5 millimeters. If the pupil size is too small, then the outer rings of the lens don't function well, and you might not have very good near vision. If the pupil size is too large, then you might have issues like glare and halos because there's too much light hitting the peripheral lenses. Another important thing that sometimes we miss is the angle kappa. So if you look at the picture over here, you can see that the center of the visual axis is a little off center from the center of the pupil. Okay, and we want this ideally to be to be less than 0.4 or 0.5 millimeters. If this visual axis is very far from the center of the pupil, then this might cause issues later on because there might be a misalignment between the lens and the visual axis, and this might cause reduced visual performance. So this is one number you want to look at, and generally I think many of the biometry machines and topographers will give you this number already. You just have to remember to put it in your checklist of things to do before going into surgery. Okay. So then after you've done that and you've determined the patient is anatomically suitable for receiving a multifocal lens, you have to make sure you sit down with the patient and try to find out what the needs of this patient are, and you have to set their expectations. And you have to educate them as to what to expect after the surgery. So you have to discuss the pros and cons of the IOL options. And earlier when we did the ophthalmology meteor garden, you could see an example of that interaction with the patients. And after all that discussion, the patients may themselves tell you what lens they want. But if they don't, then you can make a recommendation to the patient. And I always repeat that if I put this multifocal lens, you may see glare halos at night. Sometimes when you read, you may have to use more light. And if the patients are agreeable to all of that, then you can proceed with the surgery. I normally give them some literature also, and you can refer them to online resources so they can do their research. And sometimes it's not enough that the patient is educated, even the children may have to be educated so that everyone can buy into the product and accept the consequences. So this year I've started to study the teachings of Buddha, especially in Taiwan. I know there are a lot of Buddhists here, and this is, I think, a mathematical formula that Buddha has taught us. It's stress equals expectation over reality. And many times in life we are stressed because we expect too much, right? So if you expect, for example, that your checkout time can be delayed in the Grand Hyatt Hotel, you might get stressed when they say no way. Okay, but if you say, okay, I don't mind, it's a beautiful city, I have extra time to visit the city, then that's fine. Your stress level goes down. So same thing with these multifocal patients. If you can decrease their expectation, if you can tell the patient, you're not going to see perfectly at night when you drive your car, and you won't be able to read the newspaper when you only have a small, when you only have a candlelight to read at night, then if they see after the surgery they can't do these things, then they don't feel stressed. And if the patients are not stressed, then the surgeon, the doctor is also not stressed. They're right, Moonway. This takes some Thank you for giving me the expectation that this doesn't work too well. Okay, so I'm not stressed. Yeah, I'm not stressed. See? Okay, so just some special words about patients who've had refractive surgery, whether it's incisional or laser vision correction. These patients should already have a red flag if you're considering a multifocal lens, and if you decide anybody with prior refractive surgery, I'm not going to put in a multifocal lens, then that's fine. That's actually the safest option for everyone. But if you're more daring, then and you have a right patient who can accept that maybe they might not get optimal outcomes, then sometimes you may consider putting these multifocal lens in a post-refractive surgery patient. Okay, so these are the selection criteria. So of course you must have that available IOL power. There should be no pathology. And even if everything looks good during the surgery, if you find that the capsule is not intact, then the safest is not to implant that multifocal lens. If you cannot be sure, you can center the lens and have that thorough discussion. So one of the things we also look at is the higher order aberrations. And if you have any doubt about that higher order aberration, just put in a monofocal lens. Then you won't have any problems. But if you're more daring, the higher order aberrations are low, then you can still consider a trifocal lens. And if they're a moderate amount, then you can consider the EDOF lenses. So this is a patient that we did recently. She had myopic LASIK, but over the years she became hyperopic. Okay? So there was like an overcorrection. And now she develops cataract in the left eye, and she wants her vision corrected, and she wants her vision back to the way it was when she was 30 after the laser vision correction. So this is her refraction. She's hyperopic in both eyes. The right eye has a worse, the left eye has a worse cataract. She's 20/40 best correction, and the higher order aberrations was 0.242. So generally an acceptable normal amount. But for the right eye, you can see the higher order aberration was 0.4. Okay, so this is a red flag for putting in a multifocal lens. And since it's the left eye that's blurred, there's a bigger cataract, we decided to do this eye first. And I recommended to her that she just get bilateral EDOF lenses. And that's what we did for the first eye. We put in an EDOF lens. And she did very well. Can you advance to the next slide? Advance. Can you advance the slide? Okay. Okay, so left eye, she was very happy with her distance vision. She could see 20/20 with an Elon lens. Intermediate vision was also good, 20/30, but as expected, she didn't have very good near vision. It was 20/70, and she wanted to improve the vision of the other eye. And I was still recommending the EDOF lens, but she said she wanted to try the trifocal lens. And because her high order aberrations were high, I said, we can put it, but there's a chance your distance vision might not be good, but you probably will have better vision than this 20/70 with the extended depth of focus. And so with all the disclaimers, she agreed to the conditions. So we put in the Liberty toric lens on the other eye, and she was able to achieve 20/25 uncorrected near vision. So she's happy with the vision, but because of the higher order aberrations, her distance vision was only 20/30. Okay, but because we had this thorough discussion beforehand, and she knew what she was getting into, then she accepted the results. And her left eye, anyway, can see very well for distance, so it's a good outcome for us. But this was only possible because we had good discussions. So we now have many presbyopia correcting trifocal lenses, and I won't go into a lot of details because Thibault has explained a lot of this yesterday, but essentially with the Liberty trifocal lens, the engineers at Medicontur were able to efficiently use 7 diffractive steps with apodization to produce a lens that gives you effectively a +2.7 diopter for reading and a +1.35 diopter for intermediate distance. And I think for most patients, they will be satisfied with this outcome. And by using something called elevated phase shift technology, they're able to also give you generally a good intermediate vision. There's also evidence to show that the clinical performance of this lens is very good. You have good distance vision, good near vision, and decent intermediate vision using the Liberty lens. And just to explain the Liberty trifocal lens, this is a pupil size dependent lens. So what it means is that when you're reading, our pupils tend to become myotic, they become smaller. But with the Liberty trifocal lens, the reading part is the red line. You can see that the light distribution for reading is the highest of all of the other competitor lenses. Okay. And then when you're looking at distance, this is the blue line, your pupil becomes larger. So you can see that the Liberty also gives you the probably the highest light distribution for distance. And as we said, there's no free lunch in optics, so you may have good light distribution for near, for reading, and for far, but where do you suffer would be the intermediate vision. So you can see that the intermediate vision, the gray line, the light distribution is less compared to the others. So if we're going to implant a patient with the Liberty trifocal lens, we tell these patients, probably when you're looking at the intermediate distance, you might need more light in some cases. And this is actually quite acceptable because what's the activity that requires intermediate distance? Usually it's looking at your computer screens, your laptops. So when you're looking at your computer screen or laptop, it's easy for you to adjust the lighting level. You just increase the brightness level of your screen. And this helps with the lower light distribution for intermediate vision. But some patients, they do painting, so we tell them you should have a bright light when you're doing your painting, because that's intermediate vision. Okay, next please. Okay, so here you can see for the Liberty lens for near vision, the red, it has higher light distribution than the others. And for distance vision, that's the green, it has also higher light distribution than the other competitors. But for intermediate vision, the gray, you can see it's probably a little less than the others. So just advise these patients, you manage their expectations that if they're doing something that's intermediate distance, they may need more light or they may have to make the screen brighter. Okay, so another good thing with the Liberty is that there's less light scattering because you have fewer diffractive steps. Some of the lenses have 9 diffractive steps or 12 or 13. And the more diffractive steps you have, the more light scattering you have and the more probability for glares and halos. And bench studies have been done. Next, please. Bench studies have been done that demonstrate that with the Liberty lens here on the upper left side, you have less light scattering than the others. And this translates to probably better night vision than the other lenses. And in our series of patients, unless you specifically ask the patient if they see these disturbances, as Dr. Munwai has done, unless you specifically ask them, we actually haven't had anybody complain of nighttime disturbances. Okay, so you can see that the amount of light scattering for the Liberty lens has been shown to be less than the others. And because there's less light scattering, you expect better contrast sensitivity, better vision in low light conditions, and fewer complaints of visual disturbances. Now, one of the reasons we were sort of hesitant to use the Medicontur lenses is because of the double C-loop haptics. So we're very used to these single C-loop haptics, but we were also using the fine vision lenses because we believe this gave us greater centration. But you actually have more contact with the capsular bag using the Medicontur double C-loop haptics. So this has two benefits. One is there's better centration, and secondly, because of that contact, there's less rotation of the lens. So you expect better rotational stability, which is good when you're using the toric versions of these lenses. Okay, next please. Okay, so there have been studies that show that the lens is very rotationally stable over time because of the double haptics. Up to 5 years, there's no, it's very stable. Next, please. Okay, so next, please. So basically, the design of the haptics are optimal for keeping the capsule rotationally stable. So you expect good correction of astigmatism that's stable. Next, please. Okay, next, please. So this is a patient. Next, please. Okay, so this is a patient where we implanted the Liberty toric lens, and it'll just show you the way that we inject the lens. But before the surgery, a manifest refraction shows that there's no astigmatism, but with the biometry, you can see a 1.24 diopter cylinder, and we implanted the Liberty toric lens, and we were able to correct all of the errors of refraction. Next, please. Okay, so the video didn't play, but basically it just shows you, as with the other speakers, how the lens unfolds. Next, please. So we'll now go into our clinical outcomes. So this is the mean age. We've implanted 168 eyes with Liberty or Liberty toric. And you can see that a large number of these patients are bilateral implantations. So this is a testament to how good the patient satisfaction is, because after you implant one eye, the patient wants the vision balanced and they want the other eye implanted not too soon after. So we have a high rate of bilateral implantation. A lot of these patients, we have cataracts, but more and more we're doing refractive surgeries because the patients are happy. They'll tell all their friends, okay, I got rid of my glasses, and now we have patients coming in requesting for this same lens. Okay, so we started using the Liberty lens more and more since 2024, and now we have 2-year data on these patients. So the mean vision, uncorrected vision is 20/70, corrected was 20/50. Most of the patients were myopic. The mean pupil size was 4, and this was the average spherical equivalent and the average higher order aberration. And basically, we have very good visual outcomes for all distances. It's comparable to the other trifocal lenses. Next, please. And we also have very good refractive outcomes. And after the initial cases, for us, we find that the 119.0 A constant works best for us. We normally target emetropia or slight hyperopia if it's almost the same as myopia. Next, please. Okay, and we simply ask the patients after the surgery just to rate their satisfaction level, and the vast majority are satisfied with vision at all distances. Next, please. So for our Liberty toric lenses, it only became available in the Philippines early this year, so we've only implanted a few of them, but we're very pleased with the refractive outcomes. In general, our mean post-operative manifest astigmatism is 0.4. So with this, patients are generally happy with the quality of their vision. Next, please. And one other mention, I mentioned this yesterday, but few years ago, we did a study looking at all of our implantations with different lenses, and we found out that the mean time from the surgery to YAG capsulotomy was at 2 years in our practice. And we found that 20% of the eyes that underwent surgery would actually undergo the YAG capsulotomy. And we looked at the 2-year data of the Liberty lens, and surprisingly, we only saw 5% of the patients needing to have a YAG capsulotomy at 2 years. So I think this is a testament to how good the design of the lens is. It has 360 sharp edges, including a sharp edge at the optic-haptic junction. And this seems to decrease the chances of posterior capsular opacification. Okay, so in summary, right now we have a lot of IOL choices. We're able to give a lot of patients spectacle independence. And as we learn to use these lenses, we're able to better match the eyes with the IOLs. The important elements will be to understand the patient's needs and do careful diagnostics to be able to do a good IOL selection. Next, please. Okay, the Liberty multifocal lenses in our practice gives us good outcomes and continuous range of vision. Next, please. Patients are very satisfied with the Liberty multifocal lens. Next, please. Interestingly, we have a low PCO rate, better than the other lenses we've used. Last, please. So we think that in our practice now, this is probably the best lens we have for maximizing spectacle independence in the appropriate patients. Next, please. And we'd like to invite you all to come to Manila for the 2025 Vitreorefractive Conference. Thank you.